how to approach crusting and scaling diseases. So I'll start by saying that crust and scales are secondary lesions. And if you remember what we discussed before, it's very important always to look for primary lesions because there are many differential diagnoses if you just focus on the secondary lesions. So I think it's very important to always look for what could be the underlying cause for those crusts. Consider if the patient is itchy and consider what the distribution of the lesions are. Clinically speaking, the vast majority of crusting scaling diseases you're going to see in practice are secondary. So they're due either to a pustular eruption or to some kind of change in the sebum composition and so on. There are very few primary diseases of keratinization in which the issue is actually the process of differentiation of epithelial cells, and I'm going to cover those. But I think it's clinically speaking, it's very important that you first consider secondary causes for seborrhea. And among that, a bacterial infection being the single most common one. So the way I remember this for myself is thinking it this way. Okay, one way to have crust is to have a pustular eruption. And the pustules can be either follicular or not. So when I have a follicular disease, I think about Demodex dermatified staph, and so I put that on my list. And again, staph being the most common one when you're dealing with dogs. And then causes for non-follicular pustules is basically everything else. So I put autoimmune as one important representative of that category, let's say pemphigus, but then it could be also contact, could be parasitic diseases, and so things that basically have nothing to do with follicles, because the parasite will bite no matter where, but they will cause a papular and pustular eruption. So when I deal with these cases, I start with the basic foundation. And you'll notice that there's kind of a recurrent theme, in all these lectures that you're hearing. We'll start with the cytology, scrape, and fungal culture. That's the kind of the basic stuff, just to have a sense to cover. You're covering the three causes of folliculitis, and then you decide whether you have ruled out the basic stuff, whether you would consider additional testing, let's say biopsy. But the first and foremost important step to do when you first evaluate these cases, if you have any bacterial component, you have to treat it. If they're not on any form of flea control, you need to address that. And if they're very itchy and you think that parasites are playing a role, then you treat for that. Now, how you treat the secondary infections are going to be an extensive description about that, because Dr. Torres is going to tell you about antibiotic resistance and pyoderm and so on. But it's very important that you don't underestimate the importance of infections, both in determining the level of itching and being responsible for the crusting and scaling that you observe clinically. So if I have to kind of think in my head, what are the possible cause of seborrhea, then I divide them in category itchy and non-itchy. So if you look at the list of itchy diseases, it's something that can be itchy by itself, even in, so like parasites are itchy by themselves. Anything can become itchy if you have a secondary infection, whether it's bacteria or yeast. And then I put allergy and neoplasia, and with neoplasia, I mean lymphoma. On the other side, there are the non-pruritic diseases, so things that are non-itchy unless they're secondarily infected. So we talked about endocrine diseases already, metabolic diseases and things like that. So kind of like you have this two big categories. But when they first come to you, they may all be crusty, itchy, scaly, and you have to kind of sort out. So the first thing is figure out, are you infected, yes or no? If you're infected, that needs to go out of the way, and then you reassess. And you reassess for both itching and scaling and crusting to see what is left after the infections are done. But the single most important point is the vast majority of the seborrhea cases you'll see in practice, or that you're already seeing, are secondary in nature, with pyoderma being the leading cause. So this is the nice lesion of a pyoderma case that some people may misinterpret as ringworm, but anything that looks like ringworm in a dog most of the time turns out to be superficial pyoderma. And then many of these cases don't have the inflammatory presentation, maybe because they've seen some steroids on and off. And so what they have is they shed a lot, and they just have all these flakes and crusts. And so that is kind of like a very common presentation for superficial pyoderma. So this is not primary seborrhea, this is secondary seborrhea. Of course, you'll do your cytology. If the lesions are wet, you're going to have this type of cytology with inflammatory cells. But if the skin is kind of dry, you're just going to have a bunch of scales, and you're not going to find a cytology that is helpful that way, right? You may just find a few scales and so on, and you have to trust the fact that you're dealing with pyoderma. So don't let a negative surface cytology talk you out of treating that patient for pyoderma. Because if the skin does not have pustules, you may not have a beautiful cytology to help you, okay? So we also need to remember that pyoderma is secondary until proven otherwise. The concept of having idiopathic pyoderma, it just means that we are not smart enough to figure out what the cause is. But there's always a reason for why Staphylococcus takes over and is able to establish an infection. So we should work very hard as clinicians to figure out what is the underlying cause that can range from allergies, endocrine, parasites, rank these diseases based on the level of itch, but always strive to look for the underlying cause. If you don't, that pyoderma will continue to recur, and so you're gonna be stuck in this vicious cycle. So I'm just put some images just to kind of like highlight this concept. So these dogs all have crusty, scaly skin. This is a flea allergic dog with a secondary pyoderma. This is an atopic dog with secondary bacteria and yeast. And this is a scabies dog. So basically, they all eventually show up as crusty, itchy dogs. And so we need to kind of treat the treatable and always reassess. Always look for Demodex, whether it's, juvenile onset, adult onset. And then if it's an adult onset, always look for an underlying trigger for why that animal has now developed hemodicosis. We talked about, Dr. Torres talked about hypothyroidism. So hypothyroid dogs can develop secondary pyoderma, and so plus their sebum is not normal, and so they are prone to have this crusty, scaly presentation. But once again, it's very important to clean up the secondary bacterial components so that you can reassess and see what is left. So we talked about pustular diseases due to like follicular issues. Now I'm talking about pustular diseases that are non-follicular, like pemphigus. So again, it's a crusty presentation due to the dry pustules that are non-follicular, but they're autoimmune in origin. Dogs can get it, cats can get it, and your cytology helps you. The distribution of the lesions already helps you to think about pemphigus because it's a disease that starts on the head, while the pyoderma is typically truncal disease. And then when you do your cytology, you will also see the acantholytic cells, which are these nice blue cells, that you, and then you kind of like, you can put these things together and think that, you know, you rank pemphigus foliaceus higher on your list of differential diagnosis. But some may look like this. This dog had pemphigus, but it could look like just a bad case of seborrhea. Of course, he has a lot of dry pustules and so a lot of scabs and crusting and scaling. You will hear much more about malassezia later today. Malassezia is a common cause for secondary seborrhea. You know, sometimes can be a seborrhea oleosa, so like a greasy crusting disease, and you'll do your cytology looking for yeasts. Just a few things to keep in mind about malassezia. Malassezia is frequently goes together with staphylococcus, right? So, and it likes lipids as a general thing. It's kind of like lipophilic and has a symbiotic relationship with staphylococcus. While in humans, there is a competition between bacteria and candida. In dogs, malassezia and staph, they kind of go together. So they have the same underlying diseases. This is why, let's say, allergic dogs, they frequently have bacteria and yeast, and then you treat one, and then the other one becomes more obvious. But it's not the antibiotic treatment that makes them prone to malassezia. Sometimes owners may misinterpret that quote, you caused the yeast infection by giving an antibiotic. You just made that yeast infection more evident by removing the staphylococcus, but they kind of go together, they help each other and have this symbiotic relationship. And so many of these allergic patients have these combined infections that need to be properly diagnosed and treated, because in my experience, particularly if you miss the yeast, it doesn't matter how good your antipruritic treatment is. Malassezia is very itchy and many times does not respond to steroids or Apoquel or cyclosporin, and you just need to kill malassezia. And then one thing to keep in mind, that it's not just about the number of yeast that you're going to find on your cytology. Some animals can become allergic to their own yeast, so very few yeast can be very clinically relevant. So you just go based on the severity of the clinical signs to help you decide when it's necessary to treat that infection or not. And again, hypersensitivity to malassezia plays an important role, and so that is why you have this severe inflammation and pruritus in many of these cases. Okay? So again, we're kind of now covering all the secondary causes for seborrhea. We talked about neoplastic diseases like lymphoma already many times. This is just a slide to remind us that mycosis fungoides can look like many things, and some old dogs that just get inflamed and crusty and scaly, and that is a secondary manifestation of seborrhea, right? So it's not a primary disease of keratinization, it's a secondary seborrhea. But now let's take a look at what is an actual primary disease of keratinization. In order to do that, I would like to start with the basic definition of what keratinization is. If you think of the epidermis, these keratinocytes need to move from the bottom to the top, and by doing this, they have to undergo a process, changes in the type of protein that they have and shape and so on. So keratinization is basically the process of differentiation of these epithelial cells. And the diseases of keratinization are diseases in which basically this differentiation process is affected. And again, clinically speaking, can be dry seborrhea or oily seborrhea, but the point is that the keratinocyte and the sebum production are affected themselves. And if you have any disruption of that, you have a disruption of the skin barrier. Therefore, you also have an increased predilection toward secondary infections. So that's why the secondary infections always end up complicating the clinical picture. So again, this is kind of like to describe how the keratinocytes change shape to go from the stratum basale all the way to the top to become dead, flat cells, okay? So that is, this whole process is the process of keratinization or differentiation. Without getting into too much detail, but just some basic idea of what that means is that new proteins need to be synthesized. And I'm just going to mention two because they play a role in disease of keratinization. One is keratin, which are different types of keratin depending on where you are in the skin. The other one is filaggrin, and this is important because there are diseases of keratinization that affect filaggrin. But also, in the upper layer of the skin, it's very important to have the proper amount and distribution of lipids. You heard about all these topical products that we now have available to restore skin barrier function. So the organelles that are containing all the precursors of the ceramides are called lamellar bodies. And these lamellar bodies are basically released as the keratinocytes matures and differentiate. So if there is any issue with that, you have altered lipids in your skin, therefore impaired skin barrier. So filaggrin is a key protein. It's a key protein because when we talk about atopic dermatitis, there is increasing evidence that filaggrin is affected, whether it's a primary change in filaggrin, genetically inherited, or it's a secondary. But think of filaggrin as a glue that holds all the keratin filaments together. So filaggrin is basically present in the keratohyalin granules, which are just blue granules here. And so it basically plays a role at this level onward. Okay, so the juncture with the stratum corneum. Very important protein. And again, this is released, you can see this level of the epidermis is critical because the junction between the stratum granulosum and stratum corneum is also where the lamellar granules or lamellar bodies are releasing their lipids. So they need to be able to release these lipids. If there is any issue in the release, you have a disease of keratinization and you have an impaired skin barrier. And without getting in too much detail, but I want you to remember that ceramides are critical for proper skin barrier. This is why when we do also therapy, in these cases, we have all these sphingolipid emulsions that you apply topically, attempting to almost seal the skin to kind of prevent too much water loss and to minimize secondary infections. And again, these lamellar bodies are the ones that are critical at providing the key ingredient for the lipid layer in the stratum corneum. Another component to this is the degradation products of filaggrin. These are called natural moisturizing factors and basically are the leftover of filaggrin that is being metabolized. Why are these moisturizing factors critical? They keep the pH low. If you have issues with filaggrin, you have less of these factors, therefore your skin is not as acidic. If it's not as acidic, you're also going to be prone to infections because the lower pH makes it unsuitable for bacteria and yeast to replicate. If your pH goes up, which is the case of atopic dogs and atopic people, then you are going to always walk around with more Staphylococcus because you're not able to control Staphylococcus. So these natural moisturizing factors are important for a ton of reasons: to keep the skin hydrated, to protect from UV exposure, and to keep the pH low. So if there is any issue with filaggrin, you have all these consequences. So I am going to talk about a couple of diseases of keratinization by mechanism. So if you have issues with the filaggrin, two big examples are, one is ichthyosis and the other one is atopic derm. If you have issues with the extrusion of the lamellar bodies, you have atopic dermatitis, which basically is, we always think it just as an allergic skin disease, but it's actually also a disease of keratinization, okay? Because there are actually some atopic patients who are not allergic at all. 10% of them, they actually don't have allergies, they just have an abnormal skin. And then you have diseases in which the keratinocytes replicate too fast. And this, the classic example is the primary seborrhea of Cocker Spaniels. So, but statistically speaking, ichthyosis, primary seborrhea of Cocker Spaniels, they're not the most common thing that you're going to see in practice. So these are genetically inherited disease. They are not that common, and they start very young because they're genetically inherited, and they're non-itchy unless there is a secondary infection. So that is very important to remember. If I see an itchy, greasy Cocker Spaniel, there's a 5-year-old, but chances are is an allergic Cocker Spaniel that has a secondary bacterial infection. Is not the primary disease of keratinization. So the primary Cocker Spaniel, and it's not just Cocker Spaniels, there are other breeds that get also primary seborrhea. I kind of made a list here, but we typically talk about Cocker Spaniels. They start at young age with greasy ears. They're just greasy dogs, period. That's the comment that people will make. From young age, they need to be bathed a lot because they just are constantly greasy. And they have cerominous otitis, initially non-itchy, unless they eventually get a secondary infection. So if you think about the fact that a normal skin takes about 3 weeks for a keratinocytes to go from the basal cell layer to the top, a Cocker Spaniel with primary seborrhea will do this in a little bit over a week. So it's basically the skin is multiplying faster than it can possibly shed it, right? So when you see the noses of these dogs and the foot pads, they are crusty. So they have this, quote, hyperkeratosis of the nose, hyperkeratosis of the foot pads. It's just simply because of this uncontrolled replication of the keratinocytes. This is a disease that runs in families because it's genetically inherited and is particularly evident in the folds. So whether it is the antebrachial surface, the lips, axial, inguinal area, and between their toes, this basically the easy areas where you can kind of find it. You will see follicular cast when basically there is a keratin that is stuck to the hair, almost like in a cast presentation. And in cockers, it's basically a greasy manifestation. Now, you can have seborrhea in other breeds, like the Dobies and so on, and that is kind of like a dry presentation for seborrhea. But the pictures I am showing you now is just a bunch of cockers that did have primary seborrhea. So you can see that this dog here also is the nose that is kind of crusty. And then, of course, at this point also has secondary infections. But again, the ventral neck is a common area where they tend to accumulate crusts and scales. And at this point, of course, they're secondarily infected with bacteria and yeast. The commissure of the lips is a common area also where you can see all the greasy accumulation of keratin. And then they come with the history of having waxy ears from the very beginning of their lives. So that basically people keep cleaning those ears and they keep getting wax all the time. At the beginning, again, they are not inflamed, they're not itchy, but over time they become itchy because they become secondarily infected. And then, of course, they get pyoderma, so that you see more of crust in this circular appearance like this. They basically are epidermal collarettes. But again, you just have this crust and scales, whether it's on the skin or you just looking at the bottom of their feet. And look at this foot and how it looks like, and then think about the feet I'm going to show you later. So this is basically is keratin. These are not dry pustules. This is just a foot that it has too much keratin on it. So how do you deal with these cases? Well, they are prone to infections, so being on top of those infections is critical to basically diagnose them and treat them and do a ton of topical therapy, whether it is with medicated shampoos to address the bacteria and yeast, or to do a shampoo therapy with keratolytic, keratoplastic products. So what's the difference between keratolytic and keratoplastic? So keratolytic is something like sulfur that will kind of help you to remove all this crusts, right? Keratoplastic is something that should also slow down the rate of replication of the skin. Obviously, being a Cocker Spaniel with primary seborrhea, there's so much that you can accomplish, but basically many products have combination of keratolytic, keratoplastic agents to kind of remove the scabs and kind of try to normalize the differentiation of the skin. People in the past have also used a lot of retinoids to kind of slow down that replication of the skin. In the US now, it's very difficult for us to prescribe retinoids because of regulations, so most people now no longer can use retinoids. People have used steroids to kind of like also basically almost create some cutaneous atrophy on purpose, right? To kind of like slow down the sebum production and the replication of the skin. But basically it's a management, so these cases cannot be cured, they can just be managed. Now a subset of these cockers will respond to vitamin A, so it's called vitamin A responsive dermatosis, right? And so they basically look very similar to the other dogs I showed you. And they have lots of crust and scales, and again, there is not that they're deficient in vitamin A, it's just that vitamin A helps to normalize the proliferation of the skin. So that is something that for us is still an option to prescribe vitamin A to kind of see if it helps. But again, it's very important that you don't start prescribing this in every crusty Cocker Spaniel. Most of them are actually secondarily infected, and so they need to be treated appropriately. If you do want to prescribe it, this is the dose, 10,000 international units, and see if that helps. And again, lots of topical therapy to minimize the development of secondary infections. Now, there are other diseases that may look like vitamin A responsive dermatosis. Okay, we already talked about the secondary stuff, but let's talk about other ones like sebaceous adenitis and zinc responsive. But before I talk about those diseases, I want to briefly mention that in the literature, there is also the mention of this epidermal dysplasias of Westies. And for the longest time, we talked about that as a primary disease of keratinization. But now we know that many of these dogs actually had yeasts. And we were too stupid to know. And so we kind of created this as a separate disease. But many of these dogs did not have a true disease of keratinization. They were just dogs that had a tremendous amount of yeast and needed to be treated for that. If they're left untreated, that you have this kind of like a thickening of the skin, lichenification, and almost they turn into a little armadillo, right? So with all this folds and stuff. But people now really question whether the old reports in the literature, was it true that these dogs indeed had a primary disease of keratinization, or they were just dogs that needed some ketoconazole so they could basically be done with their yeast infection. Moving along on primary diseases of keratinization, I'm going to talk a little bit about ichthyosis. Ichthyosis is a congenital skin disease, so genetically inherited. So it is a bona fide primary disease of keratinization. There are many different types of ichthyosis in people. The ichthyosis in dogs has some feature of the human disease, but it's not exactly the same. Has been reported in a variety of breeds. In my experience, the one I've seen the most is the golden retriever that present early on with all these scales, and almost they look like the skin is peeling. But I've seen it also in Jack Russells and Terriers. So if you look at the picture here, of this dog here, this is not a true cross. This looks like the skin is actually peeling. So yes, it's basically, it's almost like it's desquamating. So it has a different characteristic from the real crust. If you look at this puppy here, it's almost like, it's kind of like, looks like fish scales, right? So yes, it is crusting and scaling, but it looks different. So the young age at which these animals are presented and the appearance of the lesions should make you think about ichthyosis, so that you're dealing with a congenital primary disease of keratinization. And this is why I talked about filaggrin early. So alteration of filaggrin is, in some cases, responsible for ichthyosis. So that basically you no longer have keratohalin granules, which are critical for the proper differentiation. Therefore, you are in this situation of having all the scales and incapable to have a normal desquamation. And there are many forms of ichthyosis that are incompatible with life. Okay, so it's not anything that can be fixed or can be treated. Milder cases, you know, you can kind of control the secondary infection and make them more comfortable. But severe cases typically end up being euthanized. Okay, but again, look at this, the clinical features. So it's basically this peeling of the skin. So you can do genetic testing, at least we can in the US, I'm not sure here, but if you are presented with a case like this, you can do a buccal swab and send it, and to basically minimally, if you're dealing with the breeder, to let them know that yes, they're carrying this this mutation, and therefore it's very likely that they're going to have more litters with the same condition. So like I said, the treatment is damage control. You basically use humectants and moisturizers to kind of hydrate the skin, because their skin barrier is not normal. Therefore, they cannot protect themselves from infections. And people have attempted retinoids, which obviously takes a while to see some improvement, if any. Now, dogs are not the only one that get primary seborrhea. Cats do too, and it's called dirty face syndrome, which tells you that we don't know anything about the pathogenesis of this disease, but it runs in Persians frequently, and it affects the face, and they are very prone to infections, particularly malassezia. And so damage control and treatment of the infection is critical, but there is nothing that we can truly do for this primary seborrhea itself. So the fact that they start very young, the breed, the appearance, the distribution, it makes you think of a primary disease of keratinization. And again, we end up controlling the yeast infections of these patients, at least to make them more comfortable and less pruritic. Now, there are other diseases like feline sebaceous gland dysplasia. There are very few reports, and these are, again, young animals. And that's the thing. If you're presented with a young individual, think about a primary disease of keratinization. And in this case, biopsy is the way to get a diagnosis. And these are basically diseases that cannot be cured. So this is in cats, and where you will find this distorted sebaceous glands. And again, this is a genetically inherited condition. You can have the same condition in dogs where you have sebaceous gland dysplasia. Again, very few reports, and these are diagnosed with a biopsy. What you're going to see much more commonly is acne. So acne, again, in dogs is something that you typically get in young individuals, and they frequently then get secondary pyoderma with it. And in cats, it's something that you can find at basically any age. It's not just confined to young individuals. But the important thing is that they get secondary infections. So when I look at the chin like this, I think of malassezia. So do a cytology, and not many times people treat for bacteria, and they do have a bacterial component, but it's very important to treat for yeast anytime you had the brown exudate. These dogs had a furunculosis, bacterial furunculosis. It started with chin acne, and then they got the secondary bacterial infection. Now, we talked a few times already about sebaceous adenitis. Sebaceous adenitis is genetically inherited. It runs in certain breeds like Vizslas, Poodles, Akitas, and it's an immune-mediated progressive destruction of the sebaceous glands. It's a consequence. They get crusting, scaling, frequent secondary bacterial infections. And so they are presented, depending on what stage of the disease, they may be presented initially because the structure and the quality of the hair has changed, or they started developing scaling. The Vizslas, they tend to get alopecia and almost look like a pyoderma, so like a multifocal alopecia. The Akitas, they get more of the actual follicular casts and crusting. And so this is what the follicular cast look like, where basically you have the all the keratin that is kind of hugging the hair, and that is a feature of sebaceous adenitis. And these dogs basically need to be on systemic antibiotic to treat their secondary infection. The diagnosis is done by biopsy, where you demonstrate there is other inflammation that targets the sebaceous glands, or in advanced cases, the sebaceous glands are gone. So topical therapy with moisturizing products, people have done a combination of treatments. Some people have done baby oil, propylene glycol, but basically humectants and emollients, trying to kind of restore some moisture on the skin. And then systemically, most people use cyclosporin, and particularly effective in the acute phase where you have the inflammation. Once the sebaceous glands are gone, cyclosporin typically are not that effective. Another option for seborrhea is zinc responsive. And so zinc responsive seborrhea can either be in dogs that are fed poor diets that don't have enough zinc, or it can be in actively growing puppies that, again, their nutritional needs are not met, or in huskies. And huskies can get this zinc responsive even if they're fed a nutritionally complete diet. They get this crusting around their mouth, around their eyes, on their elbows. And so the diagnosis is by biopsy, where you have this parakeratosis, so this thick stratum corneum, so the right breed, the right location, and the histopath leads to the diagnosis of zinc responsive. And so we supplement these dogs with elemental zinc to kind of correct these deficiencies. Now, if you see intact male dogs, you also notice that on the tail, sometimes they have that greasy spot, and that is tail gland seborrhea that is under estrogen, under androgen control. So testosterone basically leads to the hyperplasia of this gland, and so they have that greasy seborrhea. What are the topical options for seborrhea? We already discussed a few, but basically most products are a combination of an emollient and a moisturizer. So in oil or some humectant to kind of like increase the water content in the skin. And there are many different ingredients, from ceramides to sphingolipid emulsions. Some people use phytosphingosine because it's a ceramide precursor, or urea is something that is available as a cream and is used in people that have calluses. So when I have a dog that has hyperkeratosis on the feet or on the nose, I encourage people to use the urea. It's very cheap. They can buy it over the counter. And so it's basically something that increases the hydration of the skin so that at least it doesn't crack. So basically, you find this combination products that work for your patient, but these are the kind of the key ingredients that you will want to use. So to summarize, the take-home messages are that, clinically speaking, the vast majority of crusty, scaly patients that you see have secondary seborrhea, particularly if that did not start early on in life, but later on in life. So they're not going to have a primary disease of keratinization. They have secondary causes of seborrhea. Among the secondary causes of seborrhea, infections are the leading cause. So always look for bacteria and yeast. Treat those secondary infections and reassess to see what is left. And at that point, you can decide whether you're truly dealing with a disease of keratinization or whether you have another underlying cause, knowing that the infections are always secondary, okay? If you are dealing with a disease of primary keratinization, defect keratinization, because there's still crusting and scaling after the infections are gone, then the next step is the biopsy so that you can address, at least have an answer on what it is, and then establish a long-term maintenance plan to kind of like keep the skin hydrated and to consistently remove that excessive crust and scales. So this is what I had for you, and I may have a minute for a question or not. So
we are not taking questions right now because we are already running short of time.